Okay? Hello, folks. I think one of the deadliest assignments is to speak, to be the last speaker on a Friday afternoon at 1:18 after lunch. Now, we've been talking about culture and different cultural aspects. There are some cultures where right now we would be having a siesta. This is not being said to be suggestive, and if I see any siestas going on, I might just call you out. But I want to thank Sarah Choi and the Journal of Civil Rights and Social Justice for this invitation. The speakers who have gone before have been very informative. They've laid a wonderful basis of the history of health disparities, and I think they've done a very exhaustive and excellent job of so doing. The challenge this afternoon is really to talk about how do we respond to that. What can be done, what is being done, and how effective can that be. I ought to thank one of your board members. I drove down here yesterday from Baltimore, and I was trying to describe my experience coming down the highway. And she gave me a good term. She's not here, though, for me to give her the full credit. But she called it the aromatic farm experience, which I thought was quite appropriate. And it's quite enjoyable in some respects. Look, when Katrina was heading towards Louisiana, the Gulf Coast, I'll never forget that I was on an island called Margarita Island off the coast of Venezuela. And my wife and daughters were around me, and I said, "Oh my, this is going to be disastrous." And my younger daughter said, "Why, Daddy?" And I said, "Because New Orleans is not ready for this, and the black community especially is going to be hit hard." And that was a predictive factor in my view. We've been talking about racism and what constitutes racism and why racism and so on. And it is a very complicated issue. But we could have known a priori in the New Orleans case that the black community in the Ninth Ward was going to suffer disproportionately. As it happens, they did. And as it happens, they're still suffering that way. One of the things that I have come to realize when we talk about things like Katrina, like disasters, and when we talk about health disparities, and when we talk about cultural competency, which I'll be touching on today, it reminds me very much of the civil rights movement back in the 60s when you weren't yet thought about, but you know, you can be part of still. I'll show you how. Because the emotive aspect of what happens when disproportionate discrimination happens evokes a certain sense that you have to respond, that you can't take this, that you must do something. And back in the 60s, we used to think of ourselves as change agents, agents for social change. And we were convinced that that was true, and to some extent it worked out. In other respects, we failed. But the challenge is always in front of us. The challenge to adjust to a new reality, to a society that demands of us to make things better. And as law students, I would imagine that you face that kind of an issue on a daily basis in your courses, in your discussions. Because one presumes that one gets into the law in order to adjust injustices. So I'm making that presumption, and if I'm wrong, tell me so. But there's a warning, though, that I give myself all the time, and that is that as one discusses these issues, we have to be cognizant of the fact that we're actually trying to change minds. We're trying to change the way we approach things. And one time I gave a talk And the chap who followed me said he thought complementarily. He says, boy, that was very evangelical. And when he said that, I felt I failed. Because this is not about being evangelical. This is about being persuasive and trying to get more people to join the choir. The choir being those who are committed already to social justice, those who are committed to how to make the changes that we're talking about. So, you know, every time those of us who believe in these issues speak, we're looking to grow the choir. We're looking to make this a bigger movement so that we can, in fact, bring forth the change that we have. Remember, Katrina, other disasters, healthcare reform, all of the issues that are confronting our country is happening in the midst of an immense change in the country itself. The demographics of our country are changing every day. We're changing the makeup of our society. Hence, we're changing the needs of our society as well. So, we need to be aware of all those kinds of issues as we move into the talk that I want to give. What I want to cover is shown here. Jonathan was pointing to me every time he said Office of Minority Health. But the truth is, I am not from the Office of Minority Health. I work with the Office of Minority Health as a contractor. The Office of Minority Health, the program that I'll be describing is actually run by a gentleman named Guadalupe Pacheco, who actually was supposed to be here today, but I'm substituting for him because I run the program that he heads, so to speak. Anyway, I want to talk about Office of Minority Health, issues of the equity and emergency response, cultural competence in disaster response, a little bit about the Center for Preparedness of Underserved Communities, and then I want to really focus on some tools that I think we have that might help the issue that we're talking about. So the first few slides I'm really going to run through quickly for reasons you'll see in a minute. The mission of the Office of Minority Health is to improve the health of racial and ethnic minority populations by developing health policies and programs that will help eliminate health disparities. And the operative word there is help, because health disparities is such a large issue in our world today that it's going to take a range of programs to eliminate them, and it's going to take a long time. So we can only talk about helping to eliminate the issue of health disparities. Now, what this slide depicts, you've heard already, so I'm not going to spend a lot of time on this, but the limited ability to tailor planning and resources contributed to the lack of preparedness of minority populations. The lack of awareness or knowledge of culture and language diversity also affected communities. And the things that were said before, I don't need to repeat here. This other slide also talks about Katrina. It quotes some specific authors on this issue. And I just give you a second to gather in what is being said there, which has already been detailed in our previous speakers' presentations. Another example here of the disproportionate impact of disasters due to a variety of factors having to do with English proficiency, cultural insensitivities, acculturation level, all the things that we have heard mentioned as contributing factors to the disproportionate burden that minorities have to handle in disasters. Now, how do we address the problem? I I believe that improved language access services can help disaster responders overcome cultural and language barriers between survivors and responders, which have been cited as obstacles to appropriate emergency response. After Andrew in 1992, early relief information was provided only in English, as we heard before as well, and yet they were dealing with Latino or Hispanic populations after that disaster. Research also indicates that understanding culturally specific responses to disasters is important for reaching out to disaster-affected minority communities and for the planning and delivery of disaster mental health services, as also has been discussed. Now, cultural competence in the emergency response. This, to me, is an issue that, as a society, we have to face. Often when I talk to professional groups, particularly I have to say surgeons, for reasons I have my own thoughts about. It's never happened with lawyers though. But when you use the term cultural competence, there's a sort of immediate, knee-jerk response saying, how dare you say I'm not competent? Well, it's not being said that you're not competent. It's being said that you need to have more cultural competence. No one has ever said, I never say that people are incompetent. But professionals tend to reject the notion that they necessarily need to have any improvements because, well, you've been through law school, you've been through college. What else is there to know? But I want to introduce the idea that, all of us are engaged in a journey, and the destination is a far way off. When you talk about cultural competence, it's a daily, living, growing kind of dynamic that all of us are capable of benefiting from. But the definition that we use for cultural competence is that cultural competence or cultural competency is effectively providing services to people of all cultures, races, ethnic backgrounds, and religions in a manner that respects the worth of the individual and preserves their dignity. Worth and dignity, I find, are two very important words in life. The adaptation of preparedness, response, and recovery efforts to fit cultural context improves disaster personnel's ability to provide the appropriate and effective services in order to best meet the needs of diverse communities. Now, you would think that that would be, something that would be understood. But I'm always surprised at how often that kind of thinking is overlooked. Because here, in emergency responses, the rationale, first of all, is that you want to improve the experiences of those who are responding in order to help eliminate health disparities. And since most of our institutions are based on profit, if you wish, you want to help improve health outcomes because, in fact, it increases effectiveness and efficiency of services. So one of the other things we have to make is the business case, which says if you treat people better, you're going to have a better result, not just for the people, but for yourselves as well. Now here's what I was talking about before, about cultural competence as a journey, not a destination. I myself, I feel that I learn something new every day. I learned something new yesterday and today, just by being here. And therefore, I think the whole idea of looking at cultural competence as a journey is to be open to the new experiences that you are going to face. I'm sure as lawyers, when you go to represent different clients, you see it in Law and Order all the time. My wife's a big fan of that, so I kind of get sucked into it. But you see all the time instances of defendants who are not properly represented, defendants whose culture was not understood. All kinds of episodes have come to mind about that. But the fact is that in order to serve somebody well, you have to understand that person. You have to be able to know the context in which they're living. And so therefore, what I want to do now is to walk through the three phases of a disaster and talk about some ways to implement cultural competency during each phase. By no means would this be a comprehensive discussion, but it is merely an overview of a few cultural competency concepts as they relate to disaster preparedness. But I think it also relates to life in general, quite frankly. So first of all, the preparation phase. Most of us in this room will probably not necessarily be involved in a specific disaster event, but will be involved in something where you need to be ready to respond appropriately. So when it comes to any of these kinds of issues, we have to be ready to communicate with the community in order to ensure that the organization's early warning systems are culturally and linguistically competent. We heard earlier that we have to know and understand cultural norms and mores, use appropriate languages or language, recognize strengths and limitations, and take advantage of the strengths of communities. I always think, in whatever situation I happen to be, whether it's working with my staff or working with a group of people, that you want to heighten and emphasize their strengths, not their weaknesses. You can use the weaknesses more as punishment, and I don't like to be in that situation. So you want to emphasize the strengths, take advantage of the strengths, and find ways to buttress the weaknesses. Now let's talk about further on the response phase. This is really tailored mostly for first responders, but we talk about just-in-time training, which offers the correct information at the right time and in the right form. And then whether it's in emergency response or anything else that we do, we need to be cognizant in the recovery phase of things like depicted here. Oh, I missed that slide. I got to go back to that one. Let me explain this one. We're talking here about disparities in recovery. I wish I had a pointer, but the left column depicts how the event actually develops. You have the honeymoon, then the disillusionment that occurs as a result of the time of recovery, and then you have the coming to terms with the recovery, and then you have the reconstruction. That's on the left. On the right side, when you start having to deal with the positive and negative aspects of a recovery event, these are the sways, so to speak, where you go to a more positive side from time to time, and then a more negative side depending on the community mood and depending on how reconstruction activities are coming along. But you also have to be able to do a good evaluation of how you've done. And you probably need to do a good evaluation, not just in disasters, but in how you handle the cases that you'll be handling, whether it's about the insurance industry and how those insurance things came to be and worked out and so on. But first of all, the evaluation has to be transparent, because a transparent evaluation must involve processes that are open enough to allow stakeholders, such as local partners, project staff, etc., to see what is being done. So you need transparency. Then the evaluation needs to be independent, because an independent evaluation has to be non-biased and objective in order to be credible and ultimately useful. It also needs to be consultative in that it allows those that you're trying to evaluate and the issues you're trying to evaluate to participate in the evaluation process. And of course it needs to be relevant, because a relevant evaluation will address the needs, only a relevant evaluation can address the needs of the affected communities. Jonathan was talking earlier about a piece about the Center for Preparedness for Underserved Communities. These are the goals that they have, and this is a center that actually was developed for the Office of Minority Health, and it's based at the Office of Minority Health. Okay, so now I want to talk about some of the tools that we have in what we call the Think Cultural Health program. We have quite a few things that I think can help you in your future, and specifically people in recovering from disasters. The National Class Standards, I'll tell you a little bit about that in a second. We have e-learning programs, we have communication tools, and we have a class clearinghouse. Give you a little bit of story behind the class standards. They stand for Culturally and Linguistically Appropriate Services. Initially, they were intended to be just for health care, but we have a set of new ones coming out next month that expand the scope from health care across the board. And I think that, that they apply everywhere. In fact, two deans I have spoken to, one in a school of oral health, or rather the dental health area, and another in the medical field, who want to start implementing these class standards. And I'll talk a little bit more about that in the future. Maybe your law school might want to do that here in Lexington, if I make a good case for it. So, just a little bit more on the OMH Think Cultural Health tools. We have, first of all, a culturally competent curriculum for disaster. There is a cultural competency curriculum that we have up online, and it is at, as you can see here, thinkculturalhealth.hhs.gov. It's free, online, continuing education. It equips disaster personnel with the knowledge, awareness, and skills needed to provide emergency health care. It's accredited for first responders, emergency managers, disaster mental health workers, and dentists. And 2,500 individuals have already registered for the program, with 10,000 credits having been awarded. The idea behind each of these curricula that I mentioned is to weave through these culturally and linguistically appropriate standards, so that as you take the course, and each of these courses, I think that the disaster one runs 6 hours. The ones for physicians is a little longer, and the one for nurses is about 7 hours. And they get credits at the end of continuing medical education credits at the end of each one. So, in addition, as you can see here, as you can see here, we start out with an introduction to the class in the disaster preparedness and crisis response. Then we talk about implementing the class standards in the preparation phase, implementing in the response phase, and implementing in the recovery phase. We also have the cultural competency curriculum for disaster preparedness. From the field, we have examples and case studies, video clips, how to take vitals, fast facts. It's a very good, I think, interactive curriculum. And finally, we have guidance for integrating the communities into planning for the response, pilot testing of a toolkit, and an emergency manager's toolkit as well. So there's a lot of resources there for those people who are interested in the disaster recovery aspects. But we also have, as I was saying, other curricula as well. We have one for nurses, we have one for physicians, we're developing one for oral health, and we're developing one for what are called promotores, which are people who work in the community to improve healthcare among Latino, Hispanic members of our community. I mentioned earlier about the national class standards, which were originally promulgated back in 2000. Seems like yesterday, but it was really 12 years ago. At that time, there were 14 standards that provided a framework for all health organizations to best serve the nation's diverse communities and to inform practices related to cultural and linguistic competency in health care. As a result of their use over the years, it became clear that they needed to be upgraded, and we did this for the past year and a half. We had a National Project Advisory Committee and many other interested constituencies across the country involved in looking at how to improve the class standards, how to innovate them, how to bring them up to the 21st century standards that they need to be. So we conducted a lot of activity over the last 18 months with meetings, public meetings around the country, and many meetings of the National Project Advisory Group. And that has resulted in these new standards, which I wish I could share with you, but they're under embargo until they're released by HHS next month. But I would ask you to keep an eye out for them. I think that they can have lots of relevance to your lives as well as to the lives of people in the healthcare industry. The reason they've been expanded is to be able to be used for law, for dentists, for any institution that wants to be more relevant or more in touch or in sync with their communities. I think that as I said, that as the country continues to evolve and change, that we would be well advised to change with it, to be able to understand that change, and to be on the wave of the future rather than doing a sort of a rare end retreat, as sometimes happens in our political dialogue. Well, before I get into that, though, I better stop here and ask you if you have any questions. Thank you.
If you're a cultural competency, it seems like it's fairly broad. Are there examples of the specific cultures that you're preparing?
Oh, I think sure. I think cultural competency is something that is very broad. And the principles that are outlined in these class standards can apply to any culture. So if you're putting together, if you have an institution and you understand the community that's around you, you need to be able to deal with the members of that community, whatever culture they happen to be. So you train according to the need. using these standards as principles that you can use as guidance. Yes, sir.
I'm sorry, but what are some examples of class standards?
Okay, we have several standards. We have some that talk about the institutional need to understand the community. Then we have guidance standards that talk about taking the pulse of the community, having the right kinds of data that will inform you about what your community looks like. Then we have standards that will talk about responding to those communities, whether it's in signage or language or other appropriate kinds of material. There are some of the standards that certain federal organizations or federal agencies will use as prerequisites that you have to have in place if you receive federal funding. Those are mainly dealing with language proficiency issues. So there are 15 standards now. There used to be 14. They're now 15. And they will give guidance on all aspects of the need for cultural and linguistically appropriate standards. I wish I could have shared them with you, but if I did, I might get sued or something. I don't know what they would do to me. But they will be rolled out. I'm told it's going to be a big press conference that HHS is going to be holding at the National Press Club. I think it's going to be in April. And I could certainly send you the dates. You still will not have graduated yet, so you might still need to pay attention. But I will do that. Yes?
So I think it's pretty well recognized that there's a phenomenon in a lot of minority communities, but especially the Black community in the U.S., of this like an inherent distrust of government, which is, I think, historically based and well-founded. And I was wondering if that plays any role in development of these standards, or the government looks to work with leaders in those communities to sort of establish their own authority.
I think one of the things that distinguishes this particular initiative is that it was funded by the government, but developed by non-governmental people. The National Project Advisory Committee has 2/3 non-governmental people. All of the hearings that we held, or the public meetings, were held in communities. We had one in Baltimore, one in Chicago, one in San Francisco, and we got lots of public comments online. So my sense is that when I move around the country talking about the standards, people look to them as their own standards, the standards that they have been using in their communities, as opposed to something that the government is saying, you shall do so and so. And that's what I was alluding to earlier when I talked about growing the quiet. Because the people who currently use the class standards and appreciate the class standards are not governmental folks. They're people who are health advocates, rather, that are using these standards. And I'd like to see the size of that choir grow a little bit, because I think that the standards are not preachy. I mean, they're not beating you over the head, but they're saying, look, we have a need to do a better job of implementing our services across the country. We have a population that is changing every day in rapid fashions. We have a country that is a changing place, that is dynamic in nature. So let's try to use as many tools as we can to address the needs that are existing. But so far, there has not been a backlash of anti-government feeling. Yes?
Are there any international models that you guys looked at to guide you?
Yes, we did actually. I mean, they're, I wouldn't say to guide, but rather to inform. We looked at some of the Scandinavian models. We looked at the British model. But this is not so much about health care systems as much as issues of how do you relate better to your communities. So I personally didn't spend a lot of time on the international front because I think we have a great laboratory right here. Yes,
Yes, thank you for your presentation. I know we at Maryland are talking a lot about cultural competency as well, and I'm glad to see it being implemented in disaster preparedness. So we talked a little about structural inequality and structural racism here today, and I know that there's been a critique of cultural competency as not always addressing the underlying structural inequalities, but I want to ask you about that and how cultural competency interacts with, and mitigates the effects of these larger structural inequalities.
In the earlier talks, there was the question of where do you factor in or factor out or interchange or see the interaction of racism with societal issues and so on. And the class standards are intended to address basic issues of dignity and the worth of the individual. To that extent, they inevitably have to take note of those issues in our society that are inherently unjust. So that I see the interaction as having to be there all the time. So if you're talking about institutional inequities, okay, and those inequities are based on class and race and culture and so on, these class standards can be taken and applied to that institution in order to address the very fundamental issues that are creating the situation in the first place. Now, will they by themselves redress those inequities? Not by themselves. There has to be, it seems to me anyway, a commitment on the part of the institution itself to adopt the kinds of approaches that are called for in the class standards, to make them an institutional priority, and not, for instance, to just say, okay, in order to address these issues, we're going to appoint somebody to be the head of minority affairs. That's not the answer. It's not. This is not going to respond to tokenism. It has to. There needs to be an understanding that for us to serve any of our constituencies better, we have to reflect what those constituencies care about. We have to be aware of it, and we have to, as an institution, commit ourselves to making the changes that will allow us to provide better service. So it's all interrelated. Kind of a long answer for a short question.
Thank you. Thanks for explaining.
Yes.
You're talking about how the increase in the choir will help to implement the standards, or help to change the institution to implement the standards. From the individuals that make up this growing choir, are you hoping for awareness or funding or just participation in the organizations?
Good question. From the people who get involved, I think the most important thing is an appreciation of the value of addressing the needs of one's constituency or one's patients or one's clients. The institutions will not necessarily have to find what people like to call unfunded mandates. The institutions, I think, can respond by implementing these standards and then seeing how it accrues to their benefit when those standards are in place. The funding, okay, is always going to be an issue of where does that come from and who can afford it. And what my initial take on that is that the federal government has funded this to a very limited degree, just in terms of getting these standards set up. Now there's some hospitals that have already implemented these standards, and I'm waiting to see the data as to how much it has cost them or how much it has benefited them. So I think as they get developed, we start seeing what patterns are evolving. How is the funding coming on stream? State of Maryland just put out a big report on health disparities, which, you know, Maryland's a pretty progressive state, and yet they haven't yet earmarked any specific funding for that. Health disparities up to now has been a nice sounding term with very little oomph behind it. But I think that more and more institutions are going to start recognizing the need to make a commitment in that regard. So the commitment will come from the individual, from the institution, from the community. I mean, it's the kind. That's why I called it. It's akin to what those of us old enough to remember used to call the movement, because there are lots of different elements that are involved in making all this happen. So I hope I've addressed your point, but I can't put the percentages in place as to the money part and the commitment part, but it's a mixture. Commitment across the board, funding from some sources, implementation from others, evaluation from others, assessment, and then trying to make the case for continued development and progress. Yes?
Is this under SAMHSA, or as far as in the future looking for reporting and on the outcomes and thinking about where OMB can look to propel further support for this? Is it SAMHSA or where?
Well, the agency that is spearheading this is Health and Human Services, and SAMHSA is under Health and Human Services, as is the Office of Minority Health, which has taken the lead in developing these standards. When they're announced, they will be officially coming from HHS through the Assistant Secretary for Health, Howard Coe is his name. But so I would think that you'll see you'll be able to find out more and more of it if you go to this website, as a matter of fact, because part of the implementation aspect is for us to find ways to document the extent to which they're being implemented, to share success stories, to share difficulties, to give a picture of how this thing is developing. And there'll be cross-references all over the place. I mean, you'll see some on OMH's site, and then there'll be the HHS site. So I expect that you'll be able to easily keep up to date on what's happening with them. That answer what you're asking?
Yeah, I guess if it's in the HHS budget, it would be under the secretary's budget. Yeah. Mm-hmm. Correct. Any other questions? Well,
Well, I'm glad to say that I didn't see anybody nodding off. I appreciate that, and it's been fun being here, and I've really enjoyed sharing these thoughts with you. Thank you very much.